a recorded talk. Dr. Paul Kuo, who is the Director of Hepatology at Stanford, is going to be talking about liver transplant abstracts from AASLD. So do we have that ready to go? And I understand Dr. Kuo will be on the panel afterward, live.
Hello, I'm Dr. Paul Kuo from Stanford University. I would like to thank the organizers from the Southern California Society of Gastroenterology for inviting me to review for you today liver transplant abstracts from the recent AASLD meeting, which was held virtually. Here are my disclosures. There were multiple presentations on how changes in policy have impacted organ allocation. This paper, which looked at the impact of acuity circle policy on liver allocation, was reported by Jim Trotter. For those of you who don't practice transplant regularly, liver allocation was changed in February of 2020 to a new system termed acuity circles, whereby deceased donor grafts are more broadly shared. So here on the right figure here on the slide here, you can see they have a donor hospital, and depending on the status of the potential transplant recipient who's listed and their MELD score, as you can see here, when an organ becomes available, the organ is shared based on the radius from the donor hospital, as well as the respective status, be it 1A or 1B, and then the MELD score. The primary goal of acuity circle allocation has always been to reduce variation in MELD score at transplant for liver recipients, which has been a chronic ongoing problem for many, many years. And this report looked at the impact of acuity circle allocation during the first year. So what did the results show? On this slide, you see three different data points. You see the mean distance of organ transplant, cold ischemic time, as well as change in national median MELD score at transplant. And what the acuity circle policy implementation did was it created a policy such that organs traveled a bit further from 154 nautical miles to 199 nautical miles once the acuity circle policy was implemented. This increase in distance traveled by livers was also accompanied by a slight increase in median cold ischemic time. As you can see here, these cold ischemia times significantly went up by 12 minutes. These two changes, however, led to no difference in the national median MELD score at transplant, which remained at 28 both prior to and after acuity circle implementation. These three graphs and table also show some of the other outcomes of implementing the acuity circle policy. So in the top left here, what we have is median transplant MELD variance. And what you can see here is that there was a reduction in variance at the region level, at the donor service area level, as well as the state level when the acuity circle policy was implemented. More importantly, look here in the center. Sicker patients were transplanted faster. So what we have here are transplants per 100 active patient years. And what you can see here on the x-axis here are the MELD-PELD scores that range from less than 15 all the way up to 37 and status 1. And what you can see here is that the sicker you are, the transplant rates per active person years actually increased for the sickest patients, which was a main priority of any organ allocation transplant policy. You need to get the sickest patients the best quality organs in the shortest period of time. These changes were also accompanied by no reduction in liver transplant mortality, and you can see here on the far right graph here, this survival curve here showing that the survival rates, at least at 180 degrees, are the same, 96% pre-policy, 94.7% after the policy was implemented. And we'll await some additional data, of course, with subsequent reports. Those of you who practice liver transplant and know about exceptions that we submit know that we now transition from regional review boards to a national review board. And what this has done is this has led to a significant reduction in non-HCC exceptions. And this is shown here in the bottom row on the table here, that non-HCC MELD exceptions reduced considerably from approximately 9% of deceased donor liver transplant versus 4.9% after the policy was implemented, with also some small change in HCC exception policy and a larger number of transplants occurring without MELD exception. Again, another emphasis with any policy change. Now let's turn our attention to what has occurred because of the coronavirus pandemic, or COVID-19 pandemic. This was a report that aimed to analyze the effect of COVID-19 pandemic on liver transplant in the United States. This was a retrospective analysis from the UNOS database that occurred from March to September of 2020 and compared this to the pre-COVID period, March 11th to September 11th, 2019. The COVID period also coincided with the change in the National Liver Organ Allocation System from February 2020. These, of course, are the acuity circles that we just discussed. So here are the results here, and what you can see here is that there were differences in recipient characteristics that occurred during the COVID era, which is shown on the right column versus the pre-COVID on the left column. And what you can see here is that there were more transplants for alcohol-associated liver disease, and there were fewer transplants for hepatocellular carcinoma. Looking in the right table here, what you can also see is that the donor BMI increased and the donor risk index also increased during the COVID pandemic compared to the prior pandemic. The COVID era was also associated with a small reduction in the total number of liver transplants, although it wasn't statistically significant. However, what was significant was a reduction in graft survival and patient survival at 90 days post-transplantation. During the COVID period, this reduction was modest at 94.5% versus 95.2% for graft survival, as well as patient survival falling from 96.6% down to 96%. However, both were statistically significant. So to summarize, there were fewer transplants performed, though this was not statistically significant. More individuals with alcohol-associated liver disease were transplanted, and during the COVID period, transplant recipients had slightly higher MELD scores, lower waiting times, and a greater requirement for hemodialysis. Surgeons used organs that had a higher donor risk index, and this was accompanied by reductions in graft survival and patient survival at 90 days post-transplant. The authors also reported an increased number of rejection episodes prior to discharge, and in a multivariable Cox regression analysis for graft survival at 90 days, the COVID-19 era was an independent risk factor for graft failure. We'll have to see how these findings evolve over time as we become more acclimated to practicing transplant medicine during the COVID pandemic era. Another policy change which was analyzed at the liver meeting was on how organs are allocated for hepatocellular carcinoma. The reason for these policy changes is because the most common MELD exception has been for patients with hepatocellular carcinoma, and data has demonstrated over time that patients with HCC had significantly higher transplant rates and lower waitlist mortality rates than patients with simply decompensated cirrhosis. So the authors from University of Miami aim to determine the impact of 4 significant policy changes to deprioritize transplant for hepatocellular carcinoma on the rate of donor service area level transplants for hepatocellular carcinoma. So the 4 policies that have been implemented to deprioritize transplants are shown here. These include the implementation of a 22-point at listing with elevator policy, which is implemented from January 2005 to October 2015. This was then followed by a delay in transplant of 6 months and a cap at MELD score of 34, which was modified subsequently to a delay and fixed exceptions based on the donor service area median MELD score at transplant -3. And this was implemented approximately 2.5 years ago. Finally, this same policy was modified to accommodate the acuity circle policy that was implemented, and now fixed exceptions are based on the MELD -3 transplant score at centers within 250 miles. Their analysis also looked and determined national rate of adult deceased donor liver transplant by era, the donor service area, and calculated the annual percent change in the number of transplants with HCC exceptions across each area, and they used a joint point regression to evaluate for statistical significance. So here are their results, and what you can see here are the 4 eras. So at the top left map of the US, you see the MELD 22 policy at listing with elevator policy that occurred until 2015. And what you see in the color coding is the percent of adult deceased donor liver transplants that occurred with HCC exception points. And you can see here that red means you have less than 15%, and blue means that you have greater than 30%. And you can see here during the MELD 22 era that there are scattered states that do not transplant those with HCC MELD exception points, but other states, particularly in the Northwest and the Northeast, have higher rates of deceased donor transplant by MELD exception. The era 2 is shown in the top right, and you can see here that more states are red here, and there are still a few blue states here shown, particularly over here on the left in the Northwest again, as well as upstate New York. By era 3, which was delay and fixed at the donor service area median MELD at transplant -3, you can see here that more states, or excuse me, more donor service areas now are now red, which means that their percent of deceased donor liver transplants with MELD exceptions was less than 15%. And the latest policy, which is similar, except now using acuity circles at 250 nautical miles and the MELD at transplant -3, you can see here that the vast majority of donor service areas now are transplanting with MELD exception rates that are less than 15%. Almost all the donor service areas experienced reduction in HCC exception points, and here you can see all of the donor service areas. There were just a few that were unable to be analyzed. They're shown at the bottom right of the second column here, and then there was one DSA, which actually is in Rochester, New York, that did have an increase in their annual percent change of adult deceased donor liver transplants by MELD exception points. So the policy clearly has reduced the number of individuals who are receiving transplant with MELD exception. So these policy changes have led to fewer transplants for patients with HCC exception, no change in waitlist mortality. There is now less donor service area variability. And of course, this analysis was somewhat limited in terms of the short period, particularly for the most recent policy change. And also, of course, we're going to have to take into account moving forward how the COVID-19 era is going to affect HCC-related transplants. What about COVID vaccination outcomes in those who've undergone liver transplantation? All of us are recommending COVID vaccination for our patients who are immunosuppressed. And this report from the University of Miami examined the association between COVID-19 vaccination and COVID-19 infection or death in post-liver transplant patients. The investigators queried the veterans' outcomes and costs associated with liver disease or vocal cohort using ICD-9 and ICD-10 codes. Liver transplant recipients were included here provided they were greater than 18 years of age and in active care between December 15, 2020 to September 12, 2021. The vaccinated group was defined here on the left, and you can see these were individuals who had received either the Pfizer or Moderna vaccination, and they were considered fully vaccinated 14 days after their second dose of either of these vaccines. Unvaccinated controls were served as the population that this was compared to. These also include partially vaccinated individuals who received either one dose of the vaccine or had had fewer than 14 days follow-up after the second dose. with an mRNA vaccination, and these were censored at vaccination. Also, those who received the Janssen vaccine were also included in the unvaccinated control group, and they were also censored at vaccination. So here are the baseline characteristics of the two populations. And what you can see here is that there was roughly equivalent distribution between the Pfizer and Moderna vaccinations, not surprisingly in a VA cohort, predominantly male. And again, there were more individuals who were Caucasian who received the vaccine than who were in the control group here. And then finally, those who received the vaccination had higher rates of COPD diagnosis in their record. The outcomes are shown here on this slide, and what was found and reported was that COVID infection rates, symptomatic COVID infection rates, and death all were reduced in the vaccinated cohort, and these are shown here on these three graphs in the top left portion of the slide here. There were a total of 11 deaths in the control group and just 2 deaths in the vaccinated cohort. The authors reported that full vaccination with 2 doses of the COVID vaccine was associated with a 64% reduction in COVID-19 infection, 58% reduction in symptomatic COVID-19, and 87% reduction in death among liver transplant recipients. The 2 post-vaccine deaths that were reported in the vaccinated cohort were both due to COVID pneumonia. No antibody levels were available. Again, this is a preliminary snapshot, but does seem to imply strongly that the COVID-19 vaccine will have benefit in our post-liver transplant and, of course, other immunosuppressed populations. What about acute on chronic liver failure? There were multiple excellent presentations this year at the liver meeting that examined outcomes in ACLF grade 3 transplant recipients, because this is the one area where there is a bit of controversy. The UNOS database, unfortunately, lacks granular data to analyze these outcomes. And so in one of 2 presentations on this subject that I thought were particularly notable, this was a multi-center trial that aimed to look at 1-year post-liver transplant survival outcomes in patients transplanted with ACLF. They also examined the impact of circulatory and respiratory failure on 1-year post-liver transplant survival, as well as evaluating non-survival outcomes, including liver transplant complications and, of course, healthcare resource utilization. This cohort represented 10 centers in the United States and Canada regarding patients transplanted between January 2018 and June 2019. These individuals required care in the ICU prior to transplant. The ACLF definitions were identified using the EASL-CLIF criteria. What we have here are the cohorts that were compared in the bottom left table here, with no ACLF group, an ACLF grade 1 group, ACLF grade 2, as well as ACLF grade 3 shown here on the far right-hand side. And what you can see here is in the survival curve here on the right, that there was really no difference in post-transplant survival between the 3 different groups of ACLF populations, ACLF grade 1, 2, and 3. The length of stay post-liver transplant, ICU length of stay, and 30-day admit rates are all shown here. And what you can see here is that ACLF grade 3 does seem to consume more healthcare resources than those who are less sick with lower grades of ACLF. And I'm sure this is quite similar to the experiences all of us have had when we try and transplant these individuals who present with grade 3 ACLF. In particular, the authors analyzed both circulatory and respiratory failure and their effect on post-transplant survival. And what they found was that there was no effect on circulatory failure on post-transplant survival in those with ACLF grade 3, including those who required multiple vasopressors. There was, as you can see on the right graph here, where you have ACLF without respiratory failure on the dotted line and ACLF with respiratory failure in the solid line, there was a trend toward lower survival in those with respiratory failure. And so these cohorts are going to have to be examined, and there are going to be larger prospective trials that will be implemented to try and refine who it is who can benefit from a liver transplant with advanced ACLF grade 3. And at the same time, we want to identify those individuals while trying to reduce, if possible, the number of resources that these individuals require in order to complete a successful transplantation. Another paper examined the European experience in ACLF grade 3, and this report was from 20 European centers in 8 countries, a retrospective analysis, and they wished to describe the variability of transplant activity for those with ACLF grade 3, as well as to try to analyze potential causes and explanations for this variability, as well as the effects on survival. Their flowchart was shown here, and they included individuals who were unlisted with ACLF in the ICU, as well as listed ACLF patients who were not yet in the intensive care unit. And their cohort, therefore, included a total of 351 patients, 91 listed with ACLF, and 98 transplanted with ACLF grade 3. What the authors found was that waitlisting strategies of patients with ACLF grade 3 drove the survival rate differences that were seen in their 20-center cohort. It was not the size of the transplant center, nor was it ICU admission policies. And you can see here on the right here on this survival curve, centers that transplanted greater than 10 patients had significantly better survival than those centers that listed or transplanted less than 10 patients with ACLF grade 3. Now again, one-year survival rates still are not great here, 36% versus 20%, but this does show that if your center is willing to list these individuals and can transplant greater than 10 patients, that you have the potential to have a statistically significantly improved outcome compared to low volume centers who do not transplant ACLF grade 3 at high numbers. Let's now talk about a very interesting use for statins. And this was a paper that looked at donor simvastatin treatment as a therapy to use to improve outcomes after liver transplant. This was a randomized trial, and as all of you know, lipophilic statins are associated with many benefits in those with liver disease, reduced HCC risk, reduced decompensation episodes. In this particular study, again, they wanted to look at the safety and clinical benefits of treating donors with simvastatin compared to placebo at 90 and 180 days post-transplants, with a special focus on graft loss. The experimental group received a single intragastric administration of 80 milligrams of simvastatin to the deceased brain death donor in 2 hours prior to cross-clamping for liver graft recovery. The control group simply received placebo. And again, the primary outcome was graft survival rates at 90 and 180 days. This is the study subject flow here, and ultimately 28 individuals received the experimental treatment, 29 individuals received the or were in the control group. The donor characteristics are shown here in orange, and the recipient characteristics are shown here in green. You can see here that between the control group and the experimental group, that the two groups were well matched with regard to donor characteristics. The same thing is true in the recipient characteristics here, and you can see here a median MELD score of 16 at the time of transplantation for this particular study. Here are the results. And donor simvastatin treatment before liver transplant was safe and also showed in the per protocol analysis improvement in early graft and patient survival after 6 months. And so you can see here that there was a statistically significant improvement in graft survival and patient survival at 6 months. They also looked at a surgical complication gradient system, the so-called Clavian grading system. And you can see here when they looked at a dichotomous analysis, that is, those who had below 3A versus those who were greater than or equal to 3B, they also showed reduced complications in those who received simvastatin. Again, this was a study that was markedly hampered by the COVID pandemic, but this simvastatin strategy should be explored in future randomized trials in a multi-center context. Here are the liver test abnormalities seen in those who received simvastatin or placebo. And what the authors reported was that they noted higher rates of alk-phos GGT elevation in the simvastatin group. The other parameters measured here, INR, AST, ALT, all were not statistically different between experimental and control groups. And again, we previously discussed the Clavian-Dindo complication rate was higher in the control group with a dichotomous analysis. The last study I'd like to cover looked at the role of sarcopenic visceral obesity and its association with post-liver transplant mortality in acutely ill patients with cirrhosis. We've all become to recognize that sarcopenia in combination with visceral obesity or sarcopenic obesity is an ominous sign in patients with cirrhosis. In this particular study, they looked to define sarcopenic visceral obesity using CT-based skeletal muscle index and visceral to subcutaneous adipose tissue ratio and examine its association with post-transplant mortality. The methods are shown here. This population was inclusive of inpatients with cirrhosis who were urgently listed and transplanted within 30 days of listing during the same hospitalization over a 12-year period from 2005 to 2017 at 4 North American transplant centers. They also had to have abdominal CT scan data less than 90 days prior to transplant, and this was to be able to identify the visceral to subcutaneous adipose tissue ratio, as well as looking at for the evidence of sarcopenia using the skeletal muscle index. And here are the results from their analysis. There were 116 patients in their cohort. 1/3 did not have sarcopenia nor visceral obesity. 20% had sarcopenic and visceral obesity present. The others were either sarcopenic or viscerally obese. When they examined the sarcopenic visceral obesity cohort separately, you can see here that they really did not differ from the other group with regard to a variety of demographic factors, age, race, body mass index, or etiology of liver disease. The authors reported that sarcopenic visceral obesity was associated with increased post-transplant mortality in their acutely ill patient population with cirrhosis compared to either patients who had sarcopenia or visceral obesity alone. So if you look at the top of the slide here, what you see here is the cumulative incidence of post-transplant mortality according to the presence of sarcopenic visceral obesity, which is shown here in the solid line. And you can see here that the death rate here out to month 36 was 39% in those with sarcopenic visceral obesity and then compare that to the non-sarcopenic visceral obesity cohort having mortality of 13%. When they looked at other subgroups, which is shown here on the right, again, sarcopenic visceral obesity in the solid line has the highest mortality rate, and all of the other subgroups here shown in the various dotted lines have much lower mortality rates out to month 36. Indeed, by univariate and multivariate analysis, sarcopenic visceral obesity remains significant with a hazard ratio in the multivariate analysis of 3.83, which was highly statistically significant. So to summarize, changes in the organ allocation policies with acuity circles have led to sicker patients now being transplanted, particularly the higher MELD patients. There are also fewer transplants for patients with HCC exception. During the COVID era, we've seen fewer transplants with higher risk organs and at least preliminarily a lower graft and patient survival at 90 days. COVID vaccination leads to lower rates of infection as well as COVID-related deaths in those who are post-liver transplant. With regard to ACLF grade 3, transplantation is feasible with good outcomes, but requires a commitment and more resources, and more data is going to be required to analyze outcomes in those with ACLF grade 3 and respiratory failure. In acutely ill patients undergoing liver transplant, sarcopenic visceral obesity is a risk factor compared to sarcopenia or visceral obesity alone, and we await more data on this important topic, as well as methods to intervene to improve outcomes given the growing NAFLD population that is coming to transplantation. Again, thanks so much for the invitation to speak at this conference. Thanks so much.